Awesome. Thank you so much, Joy, and the Policy Center team for facilitating this amazing discussion and forum. We have a lot to cover in this session because we're going to highlight parity in relation to access to maternal mental health care and coverage. So before we jump in, I want to have each panelist here kind of introduce yourselves and just in your work briefly before we jump in.
Is it on?
Should be, yeah. Switch.
Okay, I'm not hearing myself. Here we go.
Yeah.
Now it's on. Good morning. It's so nice to be here. I'm Catherine Monk. I am the Diana Vagelos Professor of Women's Mental Health in Obstetrics and Gynecology, and I am the Chief of the Division of Women's Mental Health in Obstetrics and Gynecology, so I'm really emphasizing how our Department of Obstetrics and Gynecology is really prioritizing mental health. I oversee our integrated mental health service and also do research in an area that Dr. Wisner already gave us a really wonderful introduction to, the developmental origins research. So how we can look at maternal wellness or perinatal mood and anxiety disorders and how they affect the child before birth, so have 2-gen impact.
I'm Rebecca Bagley. I'm president and CEO of the Kennedy Forum. We were founded about 12 years ago by Patrick and Amy Kennedy, and really founded on the premise of parity because Patrick Kennedy authored the Mental Health Parity and Addiction Equity Act while he was in Congress, lead sponsor, and really created the Kennedy Forum in its early days to ensure that parity was implemented. We'll talk about how well that's gone or not gone at times. But we also, I've been in my role for, it'll be 3 years next month. And we also launched in that time something called the Alignment for Progress. So one of the things that Patrick and Amy have talked a lot about is the importance of having goals if you're trying to move towards systems change. And so we laid out 90-90-90 by 2033. So 90% of people screened for mental health and substance use, 90% getting the evidence-based treatments they need, and 90% moving towards recovery by 2033. And so we've been working with organizations around how they really deepen that commitment. And then parity, of course, is this really fundamental necessity, really, to move towards that goal.
Good afternoon. My name is Roxanne Rosenberg. I am the co-founder and clinical director at Anchor Perinatal Wellness, which is a perinatal mental health intensive outpatient program in North Carolina. And there are only about 30 programs like ours in the country in 17 states and territories. We treat folks who have moderate to severe perinatal depression, anxiety, OCD, and trauma. And just so you know, the programs that exist probably can support about 3% of the need that exists for acute perinatal mental health care. I'm also an advocate within North Carolina for creating a system of care for perinatal mental health. I was on the Federal Maternal Mental Health Task Force, which has been put on pause, unfortunately, as of January. And I also lead a national collaborative for perinatal higher levels of care. Happy to be here.
Thanks. My name is Liane Freels, and I run and co-own a practice in northern Alabama. After my career as a pediatrician, I went back to school, became a clinical mental health counselor. My partner and I are we represent 2 of the under 20 PMHCs in the state, most of which are in Birmingham and Mobile. And we have formed a project to serve underinsured and uninsured women, partnered with a local nonprofit in an attempt to get funding for many of the clients we see.
Thank you each so much. So just as a refresher, for our audience, the Federal Mental Health Parity and Addiction Equity Act requires insurance plans to cover mental health and substance use disorders in an equal or similar way to medical benefits, which we know is often not what actually unfolds. And so today I want to kind of start out the discussion just by centering the real world impact of this before going into kind of the nitty gritty. So I want to let a couple of you just take a couple minutes to briefly share a patient's story that really kind of illustrates this. Maybe we start with Roxanne and then Liane.
Okay, so in honor of spring, I'm going to call this patient April. And April began having severe perinatal depression, anxiety, and insomnia during her third trimester of pregnancy. She had to be hospitalized at a perinatal psychiatric unit a few days after birth as these concerns worsened into an emergent situation. After hospitalization, she stepped down, which we like to see, to our intensive outpatient program for continued support. April had undergone multiple med trials, was continuing to undergo med trials. Nothing was really alleviating her severe symptoms. A typical length of stay at our facility is about 8 weeks. And again, just so everyone knows, an IOP treats acute mental illness outside of the hospital setting. So we are a mid-level of care between hospitalization and traditional weekly outpatient therapy. And we're really underutilized as a level of care. So April stepped down to us, was with us for about 8 weeks. But by 8 weeks, she was still continuing with severe symptoms. She was still undergoing med trials. She was not able to be with her baby for more than 5 minutes at a time. And she was still unable to return to work. So everybody, I think, hearing that would see she's still continuing to need a higher level of care, right? But the insurance company issued a denial for additional sessions, and it just said does not meet medical necessity. So at that point, a provider has to decide, are we going to continue treating this patient knowing we're not going to get paid, or are we going to have to cease treatment? We continued to treat April for an additional 6 weeks until she got down to a more appropriate level of symptomology for outpatient care. We received multiple denials, again, single sentence denials that said things like, does not meet medical necessity. And then, we have to decide, does the facility eat the cost? Or is the cost passed on to the patient? And for higher levels of care, this is thousands upon thousands of dollars. So it's not something that is fair to pass on to either facility or the patient. And people are not always going to be able to keep that person in care and absorb that cost.
Just to set the stage of where I practice, in Alabama, we are in a maternity care desert. We are in a maternity mental health dark. What was that term? Dark area. I love that. And over 66% of women in our state are also in primary care deserts. So if you were over 21 and you were on Medicaid in Alabama, well, anywhere in Alabama, in our area, there is one community mental health center where you may go. So we have clients that have not, because they live so far from a hospital, they have lost their child. I've had stories of first responders not being comfortable with a delivery, delaying delivery, and she's lost her child by the time she gets to the hospital. We have clients that call the local community. We all know community mental health is in crisis, right? They're so overrun. It's not their fault. But these women come to us like Emily, right? So they don't reach out until there's so much shame and stigma and isolation, feeling like you're alone, that by the time they get to us and they have the power to make a phone call, they have to be seen. And so I now see clients that took them a month, said, similar situation. Okay, well, you're suicidal. Sorry, we'll see you in a month. Or they're seen and then they can't get in with the one psychiatrist for our area that cares for them. So it's a major issue for us, and they come to us in crisis. I can't bill because Medicaid says, no, you have to go to community mental health. So even though we're qualified and they seek care at community mental health and they don't get what they need because of the unique issues postpartum, they're not supposed to see us.
Yeah. Thank you both for sharing those stories. Catherine and Rebecca, I want to turn it over to you. We know that there is a major, shortage of mental health care providers, as Liane spoke to, that take insurance, but most specifically, significant disparities in reimbursements, for mental health providers compared to other providers. Can you explain these two drivers as they relate to maternal mental health care access and parity and coverage? Just a couple minutes each. Catherine, maybe you want to start, and then Rebecca.
Okay, so I'm going to be a little bit of the minority voice here and say that, yes, there's a workforce shortage, but it's really a workforce shortage for those who take insurance. And this is particularly true in the major urban areas. And the issue around insurance reimbursement and what the rates are, in my perspective, is intimately linked with this shortage. So I'd like to really make 4 points specifying this. New York City, which is its unique place, but is like a lot of big urban areas. What I make for a 45-minute session is across the commercial insurances is about $200. That's not what I make. That's what we get reimbursed. And then for Medicaid and managed Medicaid, it's under $100. If I want to find a provider for somebody who can pay out of pocket, they're able to charge at the low end $300 up to $400, $500. And this divergence between the insurance reimbursement rates for me as a psychologist it's the same range as it would be for a psychiatrist. So there is absolutely disincentive to take insurance to see patients, particularly when you have to factor in the huge administrative costs of providing that insurance. So I really want to underscore in so many areas, the issue is a lack of providers. And I think these providers who have expertise in maternal mental health don't get counted because they're functioning in a private practice model. And so this is very true in these urban areas. And I realize rural areas have their own problems, but if we could really leverage a cross-line telehealth, we could diminish a lot of that problem. Okay, so going a little bit deeper into this, I always have to look up what this is, the current procedural terminology, right? This CPT codes we all use for reimbursement. They really prioritize procedures over cognitive work. And I had posted an article from JAMA describing that Medicare reimburses 3 to 5 times the rate for procedures as they do for cognitive work. So this is driving down those insurance rates for any kind of mental health care work, whether it's psychopharm or, behavior therapy. And then to go a little bit deeper into this, we looked into our own data. So across obstetrics and gynecology, doing cognitive work. So what I may earn for a therapy session, what my colleagues who are doing a consultation around treatment options for cancer or for infertility, so it's those E&M codes, right? Evaluation and management, all cognitive work. They're making $350 for a 40-minute session. I'm making $200 for a 45-minute session. So this differential, all these, like if you go down to the points I'm really illustrating here, really are driving down the kind of reimbursement that we get for mental health care, and they're getting people to opt out of accepting insurance, and really, really part of our workforce shortage in accessing affordable care.
Yeah, just to mostly reemphasize those points and some work that that we've been doing and some work that some studies that have come out recently. I mean, we've seen like physician's assistants are actually making more than psychiatrists for the same work by about 30%. So like it's an interesting example that you gave and is shown in the data. We're actually working with Third Horizons. Eric was on the previous panel on and rolling out in May some information in Illinois, and then we're hoping to do it honestly in every state. Because it's showing this differential by insurance company. It's based on, there's new data where all the insurance companies have to put out their contracted rates for everything. And so we're looking with the AMA and with Third Horizons, American Medical Association, around what are the comparables to use. And we're seeing, as you're indicating, disparities of like 30 or more % in payment. But most interestingly, to reinforce your workforce point, we're seeing that as the availability of providers, the percentages are just appalling of the amount of in-network, in the physical health versus the mental health space. There's a lot of drivers to that. And a lot of different things that need to happen within the system. And one of the things that people talk about is not enough workforce. And so I think that to me is an excuse versus what can I as entity provider, as entity insurance company do to affect the system? To your point, the insurers have a huge role in that, both how they bill, like for people to be able to work at the top of their license, peers, counselors, to be able to provide service is one aspect. And then, of course, the reimbursement rates themselves and really going after that is, a major insurer role. And then, providers, they need the systems to be able to do the paperwork to be able to. So there is like a role for lots of different entities, but we're really trying at the Kennedy Forum to get that base data so that, because I think there's just a lot of reasons why, and again, nobody would agree that or disagree that there's a workforce shortage, I think, in mental health broadly in the current system and how it functions and works. And there's a lot that entities can do about that.
Yeah.
And if I could add, I would argue that maternal mental health services have added layers of complexity that deserve higher reimbursements that we just don't get because we're lumped in with general mental health. For example, there is a greater degree of medical complexity, particularly at the higher levels of care. There's a greater degree of collaboration needed with OBs, with psychiatrists, with the rest of the person's team. And there are two patients. There is the pregnant and postpartum person, and there is the infant. And yet we are compensated not at all differently from general mental health.
Excellent points. Thank you. Rebecca, I'm wondering if you could talk a little bit about, Medicaid managed care organizations and parity.
Yeah, I just wanted to bring up the point that managed care organizations are also subject to parity. They're commercial insurance companies that are under contract by the state. And so, and CMS and all that's going on, CMS plays a critical role in that because they are overseeing basically the implementation of parity by the states and to those managed care organizations. So, it's just a very important underpinning to parity is that Medicaid is actually, subject in many cases to those same laws. And it is, with all of the shifts that we're seeing and uncertainty that we're seeing across, Medicaid and across CMS, it's still important to recognize that parity is the law. And so, we can obviously enforce it in different ways and with different levels of rigor, it is still the law. So,
yeah. Thank you for that. Liane, on the ground, how is this playing out for your clients? I know you kind of briefly touched on it, but if you could kind of just, elaborate a little bit, especially when it comes to, administrative requirements, referrals, age-related limitations.
Sure. And the state plan, like I said, these women come in crisis. So there are so many steps for them to be able to access care that it can be overwhelming and they just don't get treated. To piggyback over what Rebecca was saying, there is an answer aside from just, well, there's not enough of us. Like I said, because I'm not working with an agency, Medicaid will not reimburse me for anybody over 21. So if there really is a shortage and there's not enough people, they need to expand that. I'm qualified, and it's very much reminiscent of medicine. So in most states, nurse practitioners work under a physician, so they're in supervision. But because I have, once you get your license, you have 3,000 hours of supervision to do. Because I'm under supervision, I cannot panel with any private insurance, any of them. I feel like I'm qualified, I'm doing okay. So there's that. Large majority of our clients have so many barriers already. I have a woman with 5 children and 1 car in rural Alabama that the community mental health won't telehealth with her. So it's like so it's those holes that practitioners like us can fill, but we are not being allowed to try to fill. We're not asking for more money. I wish I made $200 an hour. On Medicaid in Alabama, as a counselor, I make $64 an hour, half of which goes to the practice. And that's fine. We're not, I'm not asking for more reimbursement for my pathologic letters behind my name. I just want to be able to serve the women in our state.
Yeah, sure, briefly.
I just want to really clarify, I'm in the same boat with you for managed Medicaid. It's under 100 and it's not going to me, it's going to the service.
No, thank you. And I think you're both kind of to unify both of your points. I mean, there's just clear disparities in how, essential, mental health care providers are being treated and reimbursed compared to others on the medical spectrum. So Roxanne, I know you run or offer really intensive treatments in your practice, and a diverse, range of clients. I'm wondering if you could talk a little bit about, gaps in access to, care and coverage for military moms. We talked about this before, and I just wanted to know if you could kind of share with the audience.
Sure, and thank you so much for giving a platform for us to talk about that. So when we're talking about our military-connected families, we're talking about active service members, we're talking about veterans, and we're talking about spouses. And there are additional barriers for these people to get mental health care in the perinatal period, including sort of the bootstrap culture of the military, including a fear of career repercussions, which is very real, and we've seen it play out, and including the fact that they need permission from their commanding officer, and they need specific referrals from base. Right? So that's a whole other thing. Then we need to wait for authorization. So many, many barriers. Okay. So we get them in and you were like, okay, we can do this. And then as of January 1, TRICARE stopped paying all behavioral health providers on the East Coast. Just a stop. And I heard there were also issues with TRICARE West. So behavioral health providers on the East Coast have gone without payment for 2.5 months, because of ostensibly a change in payment processor that TRICARE is using. And payments are starting to trickle in now, but I can tell you we've gotten about 2% of what we've been owed. And for practices that are primarily serving our military families, they're suffering. And as a result, less providers are going to be available to our military families.
Thank you, Roxanne. Really important work that you're doing to help them. Catherine, would you mind, we only have about 5 minutes left, but before we go into our final question to each of you, I'm wondering if you could share just a few additional insights from your research at the Perinatal Pathways Lab around this.
Yeah, thank you so much. And it really echoes what Kathy described so well this morning. When we're talking about perinatal mental health, excuse me, we are absolutely talking about two generations, and this was already brought up, and that starts in pregnancy. So the work that my lab has been doing for nearly 30 years and many labs across the world is this developmental origins of health and disease. And I just want to really quickly illustrate this. We can see that in pregnant women who are highly stressed, that a gene in the placenta that deactivates the stress hormone cortisol from crossing into the in utero compartment, that gene is deactivated when there's high stress. That means atypical levels of cortisol are getting into the fetal compartment, and they're influencing brain behavior development, neuronal migration, the ways that the neurons get connected with each other. And this relates to all this other work out there showing that starting in pregnancy, depression, anxiety, stress, those are risk factors for the children, the future children, to have mental health conditions themselves. So again, all the work that people are doing here, it is important for the pregnant person, it's important for the next generation, 2-gen impact.
Thank you. So as we wrap up here, I want to give each of you an opportunity to kind of share a final takeaway message to, all the change makers in the audience here around parity. Maybe Liane, we can start with you and then come back.
I guess the takeaway would be, we can talk about this all day, but we have to figure out solutions. And as other panel members have stated, it's in collaboration with each other. And I think that understanding each other, I need to understand the position of a payer better. They need to understand what it's really like to practice and what's really happening. And together we can come up with a compromise,
When we talk about maternal mental health parity, I just want these higher levels of care to be top of mind. IOP, partial hospitalization, and inpatient. And that's because the need is acute, the self-pay cost is prohibitive, and because there are 2 lives on the line.
Well, I was going to mention patient-centric, so you guys have really covered that well. And I think that the reality of the work is that, there's a strong government role, of course, particularly, honestly, in like the Medicare models that then translate into commercial insurance often. And at the same time, the majority of people in the commercial area get their insurance through their company, their self-insured companies. So like we think about, I have United, but actually I have the Kennedy Forum, or we actually have Blue Cross Blue Shield. Should have said the right one. But anyway, it's the kind of, in my case, it's not because we're so small. But assuming that we were big enough, it would be because we were a self-insured company. And so the company actually has the plan. And so until the private sector really steps into parity and decides, that the companies are going to write the plans, that third-party administrators are going to get them the data they need to make sure that the plans are in compliance, that would move the market in ways that would have transformational effect. And so there's a private sector significant role, and there can be decisions, that can move that forward. And I think we're at that moment. We're in a mental health crisis, and have been for a long time. Don't see that changing anytime soon. And so, companies really need to step up and ensure the wellness of their employees, and that includes their benefits plans.
I want to say 2 more notes of caution and then end in a little more hopeful way. One is to say that we try, the mental health team, to take all the insurances that our OB/GYN colleagues take. But what happens is there's carve out. So 30% of the patients can have a delivery with one of my colleagues, but because there's not a contract with their carved out mental health insurance, they're going elsewhere. That's really a problem we need to address. I also want to be very cautious about putting, if you will, more burden on our obstetrical colleagues. Yet there are team players with us, but they're already so burdened by keeping 2 or more people alive. And I do worry that we cope with our problem of reimbursement for mental health care by task shifting to get the OBs to do that work. And I think that's not our solution and is unfair to them. On a more hopeful side, Liane, I totally echo you. Please let's talk and understand each other's perspectives so we can find solutions. And last to say that this integrated model that we've developed, and there are many around the country we've been hearing about all day, it does offer, in essence, an economy of scale because we bring in these low reimbursement rates for the mental health care, but all the other services are coming into this centralized area with the administrative team to work with the insurance companies to get reimbursed, to do the credentialing, et cetera. So there are some advantages to being direct hires in these other departments that have a range of reimbursement rates.
Let's give a round of applause to our really awesome panel here. Thank you so much for being with us. Thank you. We have some really great follow-up material around parity compliance. If you want to check out the app. And besides that, they'll be around if you want to ask further questions. Thank you.